Hi, class. This is Dr. Weaver, and I I felt a little better um, tonight, of all times, of course. And I felt like I could do a partial voiceover on CKD. This is what I actually tried to do a couple of days or so ago, but I was just too out of it, incoherent even. So I decided to scratch that one, and but I feel a whole lot better. Um, I did go to the hospital today, and there's some kind of experimental COVID treatment that they give you in the form of an IV. It lasts for about an hour to infuse. I can't think of the name of it right now, actually. Um, well, anyway, can't think of the name right off. I thought I had the paperwork here with me. But it's supposed to help minimize the viral load, I suppose, in the body. Um, and so maybe it is what is helping me feel a whole lot better than I was previously. So I know I asked you all to take a look at my PowerPoint presentation on CKD. And as I'm sure you can imagine, it's quite a bit of information. But I just wanted to make sure that you guys knew what some of my, because I have some special kind of abbreviations and such that I didn't want you to be confused by. So I figure, this voiceover would more or less clarify some of these areas of possible concern. So, while I still have the strength, I better go ahead and get started now before I um, start getting weaker again. Um, and also, I just wanted to thank you all and for your patience, um, for your kind words, and um, just hanging in there with me. This was certainly something that was unexpected, um, but uh, got to get through it. Got to get you guys through this through the end of this term. Um, all right, so let me go ahead and start sharing my desktop with you. And we will have our discussion on chronic kidney disease. We've already talked about AKI, acute kidney injury, and of course, as you should know by now, um, AKI is something that is more uh, something that occurs in amount of hours, uh, uh, maybe some days, but less than 3 months. Anytime one has declining renal function over a 3 month period of time, we then go into more of a chronic kidney situation. All right. Go ahead and present that. So as you know, the kidney function of the urinary or shall I say, excuse me, folks, I'm still trying to compose myself. So the kidney function of urinary elimination includes excretion of waste. All right, these are some of the functions of the kidneys. It also handles fluid and electrolyte balance. Um, it regulates acids and bases, and also hormone secretion um, is another job of the kidneys. Now, all that I mentioned is impaired. All that I mentioned is impaired with kidney loss, kidney function, or kidney impairment or dysfunction. And keep in mind also that because of this, every organ is going to be impacted. The kidneys has a major job function, and especially the fact that when you have a system that can impact every system in the body, that in and of itself should describe to you or should inform you how important this organ is. The kidney's job is to filter your blood, removes waste products, controls again body's fluid balance, or controls the body's fluid balance, and keeps the right levels of electrolytes. Um, all of the blood in the body, it does pass through the kidneys several times a day. So blood actually comes or goes through the kidney. This is where waste gets removed. Salt and water and minerals are also adjusted when necessary. Now, there are several main functions of the kidneys. There are more, but these are seven of the main functions. And again, let me repeat them. Acids, it controls acids and bases. It controls water or fluids. It maintains electrolyte balance. It removes toxins and waste products from the body. It also controls our blood pressure. It produces the hormone erythropoietin. Of course, the erythropoietin is what is a hormone that helps to produce red blood cells. And also, it helps in activating vitamin D, which we know without vitamin D, then you cannot absorb calcium. And of course, you should know the importance of calcium. All sorts of body needs that does require vitamin D and calcium and so forth. All right. So some things I want you to keep in mind as you think about this condition. First of all, as I've always said to you, try to do away with all the memorization. All right, and get a really sound, comprehensive understanding as to what is actually happening with these disease processes, and it just makes it so much easier for you to understand what is actually occurring when this impairment sets in. For example, as I talked about uh, the um, the function of the kidneys is to control fluids. Well, the kidneys, it either absorbs or it will excrete fluids, depending on the body's needs. All right, and so if let's say, for example, a person has too much fluids, intravascular fluids, all right, if they have too much on board, if you will. And so if the kidneys are impaired, then the kidney's ability to eliminate that extra fluid is now impaired. All right. Now, think also about your electrolytes. And so when the kidneys, or let me back up. So the body, of course, has a certain electrolyte needs. And when the kidneys are impaired, all right, and if the body needs, let's say, potassium or magnesium, um, typically if it has a need for a certain electrolyte, then the kidneys will reabsorb that particular electrolyte. And let's say let's say if you don't have enough potassium, but you have um, uh, let's see, so you don't have enough potassium, but you have too much calcium. And so then the body or the kidneys will, of course, absorb the potassium. All right. But then it will uh, it will cause a calcium not to be reabsorbed because the body has enough in the system already. All right. Same thing with let's say, and what I'm going over right now is the different functions that I went over with you, the 7 functions, kidney functions. Think about red blood cells. So with the hormone erythropoietin, it is a hormone that it is produced by the kidneys in response to the amount of red blood cells a patient has in their body. So what happens is, let's say if a patient is anemic, meaning that they don't have enough that oxygen carrying capacity in the blood. And so what happens is, as blood is being perfused to the kidneys, once the kidneys detect that there is not enough uh, uh, oxygen coming into itself, then it will sense that that the patient does not have enough oxygen, enough red blood cells, if you will. And so then it will cause the kidneys to produce the hormone erythropoietin. Once this hormone is produced, then the hormone will travel to the bone marrow, and of course, you know, in the bone marrow is the place where um, the different blood cells are produced: white blood cells, red blood cells, platelets, and so forth. But in this particular case, the erythropoietin is traveling to the bone marrow and stimulating the bone marrow to produce red blood cells. And as a result, you have an increase in red blood cells, meaning you have an increase in oxygen carrying component or capacity, if you will. And think about this: when someone is in renal failure, um, someone is in renal failure. In other words, if the kidneys are failing, those cells of the kidneys are failing. What happens? Just a moment, people. Yes. So when the kidneys are failing, which means that the cells of the kidneys are dysfunctional, if you will. These patients will not be able to produce the hormone erythropoietin, and and therefore these patients, they become anemic. One thing you'll notice with patients who have CKD is that they are severely anemic. When you think about the organs that are failing, in this case, kidney failure, think about on the at the cellular level that those cells, the cells of the kidneys that helps the organ carry out all these different functions: the acids and bases balance, the water balance, the electrolyte balance, removing toxins and waste and so forth, controlling blood pressure. The cells are not able to carry out those functions. All right. And so just think about also electrolyte balance. Or in this case, when the kidneys are failing, there would be an electrolyte imbalance. And think about all the signs and symptoms that you'll see. Let's say, for example, if the kidneys are not able to excrete potassium, think about what happens to the cardiac system, which is why we have to place these patients on a monitor and whatnot. Think about the adverse impact that and the acid-base imbalance has on the body, especially if somebody is in an acidotic state or even an alkalotic state. But and so these are the impairment issues, signs and symptoms that you're going to see in these types of patients. So I just kind of wanted to go over that piece with you, just to give you an idea of what is taking place and why. And it all goes back to those several functions of the kidneys, and now they have the kidneys at the cellular level have become dysfunctional and cannot carry out these different functions. One last one to kind of mention to you. The kidneys have the ability to remove toxins and waste from the body. And as long as the kidneys are not functioning well, then the kidneys cannot excrete those toxins and waste, and meaning that that poison, because toxins and waste is essentially poison, they begin to build up in the body, causing patients a lot of problems. So that should give you an idea of where we're going as we continue to discuss this information. And so I want you to go ahead and take a look at these objectives here when you get a chance. So the priority concept for this particular condition is elimination. And of course, that would make sense because this is what the kidneys do. It eliminates. It aids in elimination. And some of the interrelated concepts would be acid-base balance, fluid and electrolyte balance, immunity, and perfusion. All right. Now, keep in mind that AKI is most likely going to be seen in the acute care setting. Something has brought this patient in that where they were discovered to be an acute kidney injury. The difference is with CKD, a chronic disorder, it will typically be seen in the community, or patients will be managed in the community with CKD, or it can coexist with other conditions in the acute care setting as well. Sometimes, even though patients may have a patient may have CKD, chronic kidney disease. Let's say if the patient has CKD and their baseline creatinine is 2.5, right? That's high, but let's say in the context of a CKD patient, that is their baseline. If that patient develops a condition, let's say the patient develops an infection that has caused the creatinine to go from their baseline of 2.5, and now they're sitting at 4.5. A condition such as that is what we would refer to as an acute on chronic CKD, chronic acute on chronic kidney disease, because something has caused the creatinine to increase acutely, very, very quickly. All right. And so something that's caused it to go up, let's say in this case, a couple of points higher than what it would have normally gone up. And so, again, we refer to it as an acute on chronic. I mentioned that because you may read about some of this in your charts when you go to clinical. And that can kind of sound a little confusing. Someone says acute on chronic, and you're thinking, is it acute or is it chronic? I mean, it can't be both. Well, it can be both. The patient, in other words, they have chronic kidney disease. They have that for the rest of their lives. But anytime you get a significant bump in the creatinine levels, then there's an acute situation on top of the chronic condition. All right, hopefully that makes sense to you all. So, with chronic kidney disease, it is indeed a progressive, irreversible disorder, um, kidney function that does not recover, right? We also refer to it as end-stage kidney disease. We refer to it as azotemia, uremia, or uremic syndrome. And those latter terms is essentially referring to these toxins that are building up in the system. Now, as far as patho is concerned, this is essentially where you have abnormalities in kidney function that alters health and is present for greater than 3 months. Now, when kidney function, waste elimination is too poor to sustain life, CKD, um, which we also refer to as end-stage kidney disease or end-stage renal disease. So you hear about those terms as well, right? But as far as your patho is concerned, elimination of waste products is going to be too poor to sustain life, right? Now, as I mentioned, the other terms to describe CKD, azotemia is a buildup of nitrogen based waste in the blood. I want to make sure I get rid of some of this other information. See, bear with me. All right. In your textbook, it will show you some of the signs and symptoms as it relates to uremia. And it is essentially, it should just outline for you what those signs and symptoms would look like in these patients. Now, uremia, or uremic syndrome, is a serious complication of chronic kidney disease and acute kidney injury, which used to be known also as acute renal failure. It occurs when urea and other waste products build up in the body because the kidneys are unable to eliminate them. All right. Your book should also describe for you the differences between AKI as well as CKD. So make sure you focus on that in your reading as well. Now, uh-oh. I'm actually trying to change something as I move along. All right. Now, also in your book, you should read about the 5 stages um, based on the glomerular filtration rate. And the glomerular filtration rate is a test that is actually done to determine a renal impairment. All right, and there are 5 stages for you to read about there. All right. Now, to evaluate the GFR, which is glomerular filtration rate, more accurately, um, sometimes in the hospital, there may be either a 3-hour or 24-hour urine collection test that will be obtained. All right. And so essentially, you have this container that patients will void in, whether it be within a 3-hour period of time or a 24-hour period of time. All the urine within that time frame is going to be collected, placed in a container, and sent for analysis. Right. Now, remember, CKD starts with a normal glomerular filtration rate, but patients they still are at risk for kidney damage because these patients typically have abnormal urinary findings. They may have some kind of structural or genetic traits, a kind of defect that is consistent with renal disease. So, in other words, even though the GFR test may show a normal excretion, if you will, elimination, if you will, these patients have something else going on within the kidneys itself that that is pretty consistent with the fact that they are, in fact, in either at least even in an early stage of chronic kidney disease. So, in other words, don't let the GFR fool you. In other words, um, it is very possible that with these other uh, structural issues, maybe some other urinary findings, for example, a lot of protein in the urine, which is never any good. Um, these are the other findings will always have to be taken into consideration as well, and not just the GFR. Now, the patient in category 1, you talk about the 5 stages. So someone who is in category 1, who are at increased risk of renal damage, they can be at risk, let's say because of an infection, maybe dehydration, etc. Um, so even though someone is in category 1, we have to really be careful with these patients, um, and we have to watch them because even an infection or they become dehydrated, it can actually push them into a higher category, if you will, um, unless we treat them properly. Say if the patient does have an infection, we must make sure we treat the infection properly. Or if they're dehydrated, making sure we are hydrating them so that they don't progress, if you will. All right. Now, the medical team must also manage effectively conditions that can further damage the kidneys, such as patients with diabetes, patients with hypertension, or a heart failure. Because if these conditions that I just named are not managed properly, it can lead to a progression of CKD. If you think about heart failure, for example, um, when the heart is not pumping effectively, then what happens is the kidneys are not being perfused properly. Or let's say if someone has hypertension or significant hypertension, then what happens is um, these patients will get decreased perfusion to their kidneys because peripherally they're so clamped or they're so constricted that they're not able to perfuse the rest of their organs and tissues, but in this case, especially the kidneys. Right. So we have to make sure that we understand these patients' comorbidities, and to make sure that we're treating these conditions properly, so that we can slow down the progression of this renal damage. All right. Now, remember what I told you about um, the system changes associated with CKD. Look at all these systems here. You have the renal and the cardiac, hematologic, GI, cognitive, and so forth. All these systems are impaired due to CKD. These are the wide-ranging um, effects of CKD on the various system. Right. Now, when the GFR uh, is greatly reduced um, in CKD, there are many problems that are going to ensue. There's going to be abnormal urine production, severe disruption in fluid and electrolyte balance, and also there's going to be metabolic abnormalities as well. Um, these patients, they will have healthy nephrons, kidney nephrons, that can become larger, and they work very hard as the kidneys are failing, of course. And this will lead to, for a short period of time, in urine production and water elimination, um, um, in order to maintain some form of homeostasis until about 3/4 of the renal function is lost. Uh, so this is the way the kidneys more or less compensate. Again, by increasing the size of the nephrons and helping to produce the urine, um, like kidneys would normally do so. It's just that once so much of the renal function um, uh, is lost, then these patients they will at some point lose their ability to help maintain that homeostasis. And so, of course, this is when these patients are headed more towards dialysis at some very near point. Now, greater renal disease progression leads to the inability to produce dilute urine. And this can lead to what is called fixed osmolarity. As function decline, as renal function decline, then the BUN is going to be increased, and the urine output is going to be decreased. Now, extracellular fluid and blood volume is going to increase with CKD. And of course, this is what is going to lead to the fluid overload with edema. These patients will have pulmonary crackles, shortness of breath, etc. That fluid overload, right? Um, so this is a part of this impairment, or the results of this impairment. All right. Now, as far as metabolic changes, now creatinine comes from protein. That's what the CHON. Creatinine comes from the protein in skeletal muscle, right? So the rate of creatinine excretion depends on muscle mass, physical activity, and diet. Now, the serum creatinine levels remain pretty constant when physical activity, diet um, do not significantly change. All right. Now, of course, the flip side of that is when the physical activity does change, or there's an increase, let's say, in protein in one's diet, which is something that is very, very difficult for the kidneys to handle proteins when they are impaired. And of course, this is when you will begin to see creatinine levels increase. Now, creatinine is partially excreted by kidney tubules, um, um, but a decreased renal function will lead to an increased serum creatinine level. Now, urea is made from protein metabolism, and it is excreted by the kidneys, but they will rise when renal function is compromised as well. Now, in early CKD, and this is something to think about as far as what the electrolyte levels will look like, because some will be high and some will be low, depending on what stage of CKD the patient is in. So in early CKD, the sodium is going to be increased. All right. There's essentially going to be sodium loss in the urine. All right. As far as late CKD, the sodium is going to be decreased. All right. Now, sodium retention, of course, will worsen the edema and the potassium as well. Because, I mean, if you're not able to eliminate the sodium, then these patients are holding on to sodium, meaning they're going to hold on to more water. And this is what is going to cause these patients to swell more, and this will also contribute to their blood pressure worsening. So be careful about sodium dilution if retained fluid builds up. All right. In other words, because of the fluid overload, the sodium will then become more diluted, all right, because you have more fluids to this particular mineral, all right? So a volume overload will cause more of a dilution. There's also potassium. Potassium level is going to be, excuse me, the potassium level is going to be increased, meaning hyperkalemia. And you should always know your ranges, of course. Now, an increased potassium level does lead to cardiac rhythm and rate changes. And so we have to place these patients on cardiac monitors so that we can observe what is going on with them cardiac-wise. Now, the other things can cause the potassium levels to be increased as well. So, which we have to keep in mind. For example, ingesting potassium in drugs. There's certain drugs that have potassium in them. Also, not restricting dietary potassium can also lead to an increase in potassium, in serum potassium. There's also tissue breakdown can cause an increase in potassium levels. Blood transfusions can lead to an increase in potassium levels, especially if someone has a hemolytic transfusion reaction, wherein the contents of the cells leak out, meaning the potassium is leaking out, contributing to the blood serum or the serum potassium level as well. Bleeding or hemorrhage can also lead to an increase in potassium level. So we have to watch all these things. Now in CKD, acid base balance is also impacted. As far as the early part of the disease, a little change in blood pH is going to happen due to the fact that you have some remaining healthy nephrons that can still excrete enough acid. But as more of the nephrons are lost, this is going to lead to decreased acid excretion. All right, so the kidneys can no longer excrete an adequate amount of acids, and this will cause the acids to build up in the system, leading to metabolic acidosis in these patients. All right. Um, so there is a phenomenon that takes place as far as how the kidneys manage fluid and electrolytes, or rather, not fluid and electrolytes, acids and bases. Excuse me. Um, so when I ask the question, what leads to acidosis in CKD um, patients? All right. So in CKD, in CKD, um, renal excretion of hydrogen ions are diminished. All right, because remember the kidneys either um, gets rid of hydrogen ions if someone is in an acidotic state, or it holds on to hydrogen ions if somebody is in a alkalotic state. Right now, but in CKD, the ability of the kidneys to excrete hydrogen ions is going to be impaired or is impaired. So normally, tubular cells move hydrogen ions into the urine for excretion. Uh, into the urine for excretion, but for this to occur, NH4 or ammonium and bicarb helps with this movement process. Unfortunately, in CKD, ammonium is decreased, and reabsorption of bicarb is non-existent in CKD. And as a result, there's going to be an increase in hydrogen ions and a decrease in bicarb. We refer to this as a base deficit. All right. And the bicarb, of course, is the base. Now, this leads to a high count of hydrogen ions, which leads to metabolic acidosis. Now, when there is an increase in potassium, this leads to reduced kidney ammonia production and also excretion. And so that just kind of just explains to you, gives you an idea of all the components working together to control acids and bases. It's a rather complex process that I don't want you to get too lost in, but just the fact that you are aware of what is required for the elimination or control thereof of your acids and bases. All right. And you all should know this. When you see an electrolyte listed with a negative or positive sign, such as Na positive, Cl negative, etc., it is called an ion, which is a charge. And you all should know that because you've had chemistry, but I just want to just make sure you're aware of that. Now, when there is an increase in hydrogen ions, or an increase in hydrogen ion causes an increase in respirations, as the body is trying to rid itself of CO2 of CO2 as a compensatory mechanism. The breathing is called Kussmaul respirations. This type respiratory rate increases as renal disease progresses. So whenever you see a patient with CKD, you may go into some of your patients' rooms and you may witness these Kussmaul respirations. They're these abnormal respirations where they're just really trying to blow off CO2 in order to try to control that acidotic environment, internal environment. Now, the physician uses alkali replacement to buffer or counteract the acidosis. So sometimes they may give these patients bicarb in order to try to buffer the acidosis. All right. And also make sure you read your book about the other electrolytes such as calcium, phosphorus, and so forth, um, and their impact on the body during CKD. Now, as far as cardiac changes, um, patients with CKD, they usually have hypertension. Now, the hypertension can be the cause of CKD or can result from CKD. All right. And what that means is if someone has severe hypertension, all right, if someone has severe hypertension, they're so constricted that they're barely getting any blood flow to the kidneys, and that will lead to the kidneys failing. The flip side of that is someone can have perhaps some direct damage to the kidneys itself. They can have direct damage to the kidneys itself. And because of the fact that when you're in renal failure, you're not eliminating fluids, and excuse me, you're not eliminating the fluids. You're in fluid overload, and of course that causes your blood pressure to increase as well. So anyway, as far as the CKD, it can result one way or the other. All right. Now, atherosclerosis can cause hypertension. Remember, as arteries, think about the aorta, from which the left ventricle must squeeze enough blood to overcome the pressure, the afterload. But the left ventricle must squeeze enough blood to overcome the pressure and to open up the aortic valve. But when these arteries become narrow from buildup from plaque, the pressure in the arterial system rises. This, of course, will lead to hypertension. Now, this high pressure or hypertensive damages or will damage the glomerular capillaries in the kidneys. Eventually, this is going to lead to end-stage kidney disease. Now, the main function of the glomerulus is to filter plasma to produce glomerular filtrate, which passes down the length of the nephron tubules in order to form urine. Now, CKD can cause increase in blood pressure by causing fluid overload and also abnormal ROS system. Hypertension alone can damage kidney arterioles because of the high pressure and hypertension that results in, of course, decreased perfusion to the kidneys. Now, decreased kidney blood flow leads to the production and release of certain signaling chemicals such as renin. Remember the renin, um, angiotensin aldosterone system. And so, anyway, this will lead to the signaling chemical such as the renin, and of course, one would ask the question, why is that? To improve, this happens because the body's trying to improve blood flow to the kidneys. And so here's how it works. When renin is released, um, it leads to the production of angiotensin and aldosterone. Now, angiotensin causes blood vessels to constrict, and when blood vessels constrict, it causes the blood pressure to increase. Now, as far as aldosterone is concerned, um, with aldosterone, uh, this hormone stimulates the kidney tubules to reabsorb sodium and water. All right. And this leads to an increase in plasma volume. All right. Remember, the body is now reabsorbing because of this aldosterone. The aldosterone is the hormone that is causing the kidneys to reabsorb the sodium in the water, and this is going to in turn lead to increased plasma volume. And remember, high volume of blood in the vasculature results in a higher blood pressure. Now, the problem with this increase in blood pressure, it does not always result in increased blood flow to the kidneys. Usually, we say patients need a good blood pressure to have adequate perfusion to vital organs. But in this case, the high pressure does not result in better blood perfusion to the kidneys. Actually, in this case, the production of renin continues, and it leads to a cycle of vasoconstriction in kidney arterioles, peripheral arterioles, and this will lead to unmanageable severe hypertension. And as a result, this will lead to worsening kidney function. um, Now, this hypertension excuse me, students. Now, this hypertension leads to coronary artery damage and also poor coronary perfusion as well. All right. Give me just a moment here. this sort of gives me a little time to rest my voice as I take care of a few of these housekeeping issues with my presentation. Oh, all right. So as far as hematologic immunity changes, so we are moving down the list. We're almost at the end. Anemia is common in the latter stage of CKD, which worsens CKD signs and symptoms. And again, it is due to decreased levels of erythropoietin. This leads to decreased white blood cells. Now, there's also there's a decrease in red blood cell lifespan from uremia. Uremia is that toxin, that poison that builds up in the blood because of the kidney failure to eliminate the toxins. And remember, red blood cell life cycle span is roughly about 120 days. But when someone has a certain level of toxins, such as uremia, building up in the blood system, the lifespan of the red blood cells are cut pretty short. I believe no more than 25, 30 days, as opposed to the normal 120 days. Now, this results in iron and it results in iron and folic deficiencies. Right. Now, uremic toxins also destroys excuse uremic toxins also destroys the white blood cells, and so the defenses are compromised, and this can lead to infection. Right, white blood cells cannot survive in such a toxic environment. And remember that one of the interrelated concepts I mentioned earlier, and how immunity is one of the interrelated concepts, and this is what we're talking about here. White blood cells are destroyed, and of course, you don't have the fighting soldiers to defend the body, of course, from the enemy. The next one is GI changes. The uremia has an adverse impact on the entire GI system as well. So, for example, the normal flora of the mouth change with uremia. The mouth contains an enzymes called urease, which function is to break down urea into ammonia. This ammonia generally remains and leads to what you have heard of this term before, I'm sure, halitosis. Halitosis and also stomatitis. Also leads to hiccups, nausea, vomiting, as well as anorexia. And as you can tell just by hearing what I just mentioned, nausea, vomiting, anorexia. It means that these patients are going to be very malnourished, right? These are some of the takeaways as you hear me discuss each systems component and how it is impacted by this condition. And there's also cognitive and functional changes. These patients, they have cognitive impairment, late stage of the disease. This can also be due to increased systemic drug toxicity risk, because as we know, the kidneys helps to eliminate drug metabolites. And because the kidneys are impaired, then they're not able to eliminate those metabolites. And of course, it is that buildup to toxic levels, if you will. So as far as the etiology, incidence, and prevalence of this disease, about 25% of patients receiving treatment for end-stage kidney disease are going to die in the first year of dialysis. All right. In your textbook, there should be a section that deals with ways to prevent kidney and urinary problems. I should have had my other book open so I could actually list off some of those, but I want you to defer to your book as well. All right. Well, so so for example, people need at least 1 to 2 liters of fluid to flush out waste products, right? And so what this basically means is, and especially as far as health promotion and maintenance, when you are having discussions with patients who are at risk of CKD, these are some of the things that you will encourage them to do. Again, drinking at least 1 to 2 liters of fluids in order to flush out waste products. Water, of course, is an ideal flushing agent. I know some people don't really like water, but this is a part of our teaching. This is a part of our teaching. And also, these patients have to have renal function tests and serum levels of creatinine performed in their physician's offices periodically. Again, especially when they are at risk. All right. These are things that we have to encourage our patients to do. Now, diabetes and hypertension are two of the main causes that leads these patients to having to go on hemodialysis and a need for kidney transplant as well. All right. So these conditions, again, they have to be managed and stabilized. Now, African Americans population does have a higher risk. Now, CKD is also rising. but it is affecting more older adults. Approximately 11% of Americans do have CKD, and that's pretty significant when you think about it. That's like well over 30 million people in the U.S. Right? Now, there are certain causes of CKD. That your book should also outline for you. In other words, certain conditions such as TB, pyelonephritis, diabetes, hypertension, glomerulonephritis. That is always a hard one to pronounce, etc. So just take a look at your book at the different causes that it lists. Now, here's a very important slide in terms of health promotion and also maintenance, and something that you will also see on your NCLEX exam in the future. We have to be able to be more proactive and trying to teach our patients the right health practices in order for them to avoid any at least further progression of CKD. And so what we're trying to do is control diseases that leads to CKD. So say if someone has diabetes or hypertension, then we have to get these patients into our healthcare settings. And some of this would mainly be, in the outpatient setting. But we have to get these patients in and identify who they are. We have to evaluate them. Let's say if their blood sugars are known to be really out of whack, or their blood pressure is normally seen at 200 over 130, then we have to get these patients in. We have to talk to them. We have to put them on the right drug regimen and other healthy practice regimens in order to control for CKD. There's also dietary adjustments. There's weight maintenance. There's also smoking cessation, exercise, and limitations of alcohol as well. All right. So controlled diseases that lead to CKD, such as diabetes and hypertension. There may also be dietary adjustments, such as restrictions on sodium and protein. Remember, the kidneys, only when they're healthy, they can manage a certain amount of proteins, but when the kidneys become more damaged, then the proteins are very harsh on the kidneys. And so sometimes we have to involve dietary in the mix in order to place these patients on a limited protein diet, protein intake, in order for the kidneys to be preserved longer. Weight maintenance, such as achieving an ideal BMI, course, we mentioned smoking cessation, exercising, like intense 30 to 60-minute activity. There's also limitation of alcohol. We also want to teach these patients to adhere to their drug diet regimens and exercises, which prevents blood vessel changes and kidney damage that results in CKD. So these modalities can help prevent those changes in the blood vessels. We must also teach better glucose control. We must teach better blood pressure and hypertension management, because it can result in less damage to the blood vessels. We also teach high-risk patients with diabetes and hypertension to do annual testing of the urine, albumin, creatinine levels. Also, their serum BUN and creatinine, so they should be tested at least annually. And we also must teach them to adhere to antibiotic treatment regimens if they have a kidney infection, because remember, the kidney infection can further progress the CKD condition. We also want to teach them how to, that they must increase their fluid intake unless it is contraindicated in patients such as CHF patients, for example. Also, we must teach patients to limit the amount of NSAIDs as they do limit the blood flow to the kidneys. All right. It has it has a way of you see, the kidneys has a way of auto-regulating its own blood flow, despite of what the systemic blood pressure is. Say if the systemic blood pressure is dropping, well, the kidneys auto-regulates its own blood pressure for a certain period of time, which is good for the kidneys. When these patients are placed on NSAIDs, NSAIDs affects or adversely impacts the that auto-regulatory mechanism, and so it can impact it to the degree where the kidneys can no longer control its own blood flow. And so these patients should be on a limited amount of NSAIDs, if any, your Motrins and so forth. High dose, long-term effects of this medication can affect the kidney function. So we must be very diligent in teaching our patients about that. Now, most CKD patients are managed in the outpatient setting. Now, to be successful in disease management, these patients must be fully engaged. Now, CKD patients at risk for they're at risk for many health concerns, and therefore require a pretty comprehensive team of professionals such as dietitian, nurses, mental health therapists, etc. A weight gain might point to fluid overload, and of course, conversely, weight loss may be due to the fact that the patients are anorexic from the uremia. Remember, we talked about that. Now, many conditions such as hypertension, diabetes, lupus, TB, etc., can lead to CKD. Right. Also, something that you may hear your patients tell you is that um, whenever they eat meat, that the meat has a distinctive metallic taste to it. There's also increased bruising and bleeding, and this is due to the fact that platelets are impaired due to the toxins that are building up in the patient's body. All right, and so it can lead to bleeding and bruising as well. Now, signs and symptoms of excess waste, especially uremia. Um, all right, let's see. So when someone has this excessive amount of uremia that is building up in the body, this is going to lead to symptoms such as nausea, vomiting, and diarrhea. Uh, Keep in mind, as I mentioned to you earlier on the previous couple of slides, and how the impact of CKD on even the GI system. These patients also may suffer from pretty bad hiccups as well. Now, fatigue is also common in CKD patients, especially those who are receiving hemodialysis. All right. And of course, remember the anemia, because these patients are not producing erythropoietin, meaning they can't produce red blood cells. All right. Now, also what is important, impending pulmonary edema and neurologic degeneration, signs and symptoms can occur as well. These patients may begin to experience weakness, drowsiness, as well as shortness of breath. All right. Bruising and bleeding result from hematologic changes from the uremia, that poison that is building up in the body. And it also has an effect on coagulation as well. Right. As far as GI and GU problems, um, important questions to ask about elimination problems. We want to know if these patients, the frequency of urination, the appearance. We want to know what the appearance of the urine is. Also, if they have difficulty starting and controlling the urine as well. And these are just some important assessment questions to hone in on. And so take a look at some of the assessment findings that will be noted in these patients. Um, these patients will have these neurological and sensory changes, fluid overload, tachypnea, hyperpnea. They will experience anemia, abnormal bleeding, um, foul breath, mouth inflammation or ulceration, also osteodystrophy. They may also have protein, sediment, or blood in the urine. And also, they may experience skin discoloration as well. All right. Now, remember what I had just mentioned to you, how CKD or the toxins itself can have an impact on coagulation. And of course, as you read here, talks about abnormal bleeding. Of course, the anemia, it's in and of itself, can come from the fact that the kidneys can no longer produce enough erythropoietin. So just think about all these symptoms and how they are all connected, if you will. All right. So it is very important for you guys to understand um, the very significant impact that this condition has on patients and their family members. And of course, being compassionate and understanding and supportive is paramount here. The changes that they go through is um, it's mind-boggling. Um, Sometimes we just don't understand, or we really do not cannot appreciate uh, how important our kidneys are. All right, until you begin to see many of the things that we discussed in these types of patients. All right. Now, from a psychosocial assessment standpoint, we're considering anxiety and fear, coping styles, how these patients are coping, their family relations, do they have the proper support, the social activity, are they more isolated now, or do they have enough folks to help them through this process, this illness process. Also, work. At some point, these patients will be too debilitated to hold down a job. There's also body image, because the bodies of these patients, they do change significantly. So, and of course, sexual activity. This condition is just so life disrupting. And so all hands on deck for these types of patients, because they are very complicated patients to manage. Now, these are some of the diagnostic assessment tests that we look at. Early CKD urine tests will show protein, glucose, red blood cells, white blood cells, etc. The latter part of CKD, these patients, they will have a decrease in urine output. The urine osmolarity is also going to be increased, more concentrated. And what we do is we monitor the GFR trends. All right. Now, the GFR are estimated from serum creatinine. We look at age, gender, race, as well as body size. This is why the GFR is a much better test, even better than the BUN and creatinine levels that we would normally obtain. We still obtain those tests, but the GFR is so much more accurate, more specific, because it takes more information into account. Now, the GFR is used to estimate the amount of drug dose patients are receiving as well. It can help in that effort as well. These patients, we may have to perform either a 3-hour or a 24-hour urine test that looks at the creatinine clearance. And so this can be very useful as well. Now, patients with severe CKD, they have a serum BUN, creatinine levels are done to determine the degree of uremia. Now, remember, creatinine levels is determined by by muscle mass, diet, as well as activity. And BUN levels determined by the amount of protein intake. Without protein restrictions, the BUN levels will be increased. Now, fluid levels also affect the BUN as well. So just keep that in mind as we look at some of these tests. As far as imaging assessment, a bone X-ray of the hand will show what we call renal osteodystrophy. I did provide a definition for you for that in here somewhere. Now, the X-ray can show also a shrunken kidneys, which happens with long-term CKD. And they're smaller due to atrophy or fibrosis because they're not functioning, and so they will atrophy at some point. A CT scan or ultrasound can view for obstructions in the kidneys, if CKD occurs suddenly. And so these tests can determine if there's something that's blocking um, the normal pathway of urine, if you will. Now, this is what we call priority collaborative problems. All right. Anytime we think about any disease processes or disease process, we always have to wonder to ourselves, what are the problems that I need to be focused on? What are the priority concerns here that will require my nursing intervention or attention, if you will? And so I listed here on a few slides, actually, I listed here some of these nursing priorities that will help you to hone in on what is most important. I mean, there can be 20 different things to look at, but the first few here that I've listed will inform you what the concerns are that must be looked at first in order to make sure the patient has a good outcome. So obviously fluid overload due to inability of disease kidneys to maintain body fluid balance. There's also potential for pulmonary edema due to fluid overload. You see how important this list is so far. Decreased cardiac function due to reduced stroke volume, dysrhythmia, fluid overload, and increased peripheral vascular resistance. There's also weight loss due to inability to ingest, digest, or absorb food and nutrients as a result of physiologic factors. Potential for potential for infection due to skin breakdown, immunity related kidney dysfunction or malnutrition, potential for injury due to effects of kidney disease on bone density, blood clotting, and drug elimination. There's also fatigue due to kidney disease, anemia, and reduced energy production. And my last two on my list, I think, anxiety due to change in health status, economic status, relationships, role function, threat of death, lack of knowledge about diagnostic tests, disease process, treatment, loss of control, or disrupted family life. I know that's a whole mouthful, right? And potential for depression due to chronic debilitating illness. So that's a pretty comprehensive, maybe not all inclusive, but a pretty comprehensive list to keep you started and and to mainly keep the patient alive. That's what's really so important about that list. So, what I'm going to do, I'm going to stop on slide 15. It is about 1:30 in the morning. And so what I would like to do is pick back up with this tomorrow morning, starting with slide 16, because I think I should be able to finish this presentation. And that way you will have this to take a look at as well. Let's see, is there anything else? I think I may have about maybe about 8 more slides, if that many, after when I begin tomorrow. So we went through quite a bit of it. I'm feeling a little dizzy, and I feel the effects of this condition coming on me. So I don't want to overdo it, more so than I already have. At any rate, I certainly appreciate you guys for listening in, and hopefully you will find this helpful, and hopefully I didn't sound too incoherent, which is what I was mainly concerned about. And so until tomorrow, thank you, everyone.